This video will focus on treating the burn wound, covering various management techniques and associated patient care aspects. Escharotomy is an emergency surgery needed for circumferential full-thickness burns to limbs. It involves incising the full length of the burn in the mid-axial line, avoiding major nerves. Burn wound management is consistent regardless of size. The burn must be cleaned, and its size and depth assessed. Deep burns need antibacterial dressings to delay colonization. This image shows a full-thickness burn to the upper limb with a mid-axial escharotomy. Note that the soot and debris have been washed off. This scene highlights the key features and proper placement for an escharotomy procedure. For full-thickness and obvious deep dermal wounds, the next slides detail the 4 most common dressings used for contaminated wounds. One option is dressings with nanocrystalline silver, such as 1% silver sulfadiazine cream. This offers broad-spectrum prophylaxis against bacterial colonization, especially effective against Pseudomonas aeruginosa and MRSA. Another option is 0.5% silver nitrate solution. It's highly effective against Pseudomonas colonization, but less active against some gram-negative aerobes. A major disadvantage is the need for frequent changes and the black staining it causes. Mafenide acetate cream is popular, especially in the US, often used as a 5% topical solution. However, it is painful to apply. The 4th dressing is silver sulfadiazine and cerium nitrate. Cerium nitrate is particularly useful for full-thickness burns, forming a sterile eschar, especially when a conservative treatment option is chosen. Superficial partial thickness wounds and mixed depth wounds heal easily. The focus for dressings should be on ease of application, pain reduction, simplicity, and local availability. For heavily contaminated burn wounds, formal cleaning under general anesthesia may be necessary. For more chronic contamination, silver sulfadiazine cream dressing for 2 or 3 days is highly effective. Exposure is the simplest method for superficial wounds. Initially, frequent linen changes manage exudate. After a few days, a dry eschar forms and separates. This is often used for small burns on the face and in hot climates. Another method is covering the wound with a permeable dressing, like Mefix or Fixamol, allowing it to dry while preventing adherence to sheets. Vaseline-impregnated gauze with or without an antiseptic can also be used, backed by swabs to absorb exudate. Vaseline gauze prevents swabs from sticking and reduces the stiffness of the dry eschar. Swabs need changing after the first 48 hours when they are often soaked and can be left longer afterward. More interactive dressings include hydrocolloids and biological dressings. Hydrocolloids are flexible, adhesive, gel-forming dressings changed every 3 to 5 days. They are useful in mixed-depth burns, aiding debridement and promoting epithelialization. Biological, synthetic, and natural dressings provide good healing environments and don't need changing, making them ideal for superficial burns. However, they are not as useful in mixed-depth wounds. Early debridement and grafting are key for deeper burns. Additional aspects of treating the burned patient include analgesia. For small and superficial burns, NSAIDs and paracetamol are used, along with topical cooling. Large burns require intravenous opiates. Avoid IM injections in acute burns over 10% TBSA. In the subacute phase for large burns, continuous analgesia is needed, starting with infusions and continuing with oral tablets like slow-release morphine. Powerful, short-acting analgesia, sometimes requiring an anesthetist, should be administered before dressing changes. Monitoring and infection control are crucial, as major burn patients are immunocompromised. The burn wound provides large entry points for pathogenic and opportunistic bacteria and fungi. Infection control requires sterile precautions, hand washing, and preventing cross-contamination. Regular swabs should be taken to monitor for potential infections in these susceptible patients. Signs of infection include a significant rise or fall in WBC count, thrombocytosis, and decreased clinical status. Antibiotics are used, guided by guesswork or swab culture. Burn patients require intensive nursing care. Bandaged hands and joints are stiff and painful, needing careful attention. Personal hygiene, including baths and showers, is time-consuming and painful but vital. Physiotherapy is essential, as all burns cause swelling, especially in the hands. Elevation, splintage, and exercise are necessary to reduce swelling and improve the final outcome. A major burn is an overwhelming event causing post-traumatic reactions, including intrusive, arousal, and avoidance reactions. These are normal and usually self-limiting. suspending the patient's sense of safety and overwhelming their coping ability.